Welcome to episode lucky number 13 of the ARME Radio podcast, the show where we aim to offer accessible education to healthcare and fitness professionals alike and to bridge academic research to the clinical setting. In today's episode, we're joined by Dr. Bronnie Lennox Thompson. Bronnie is an occupational therapist and recently completed her PhD at the University of Otago, developing a theory of living well with chronic pain. She's also worked in the field of pain management for most of her career, with additional roles in the realm of pain psychology, vocational management, and policy development. She currently teaches at the postgraduate level in pain and pain management, with a particular focus on psychosocial factors, coping, and resilience. We had the privilege of discussing a wide variety of topics in the field of chronic pain management, including communication, the use of exercise, or as Bronnie puts it, meaningful movement, but we also get an interesting perspective, as Bronnie has also lived with chronic pain for most of her life, having previously been diagnosed with fibromyalgia. For more information and resources, be sure to visit us at www.thearme.ca, give our Instagram page a follow at thearme.ca, and without further ado, we hope you enjoy today's episode. Oh, there's a cute puppy.
Hello.
Nice background.
Thank you. This is near one of my favorite spots by the beach. It's about 25k, I don't know what that is in miles, on gravel road out towards a pretty stony beach it's just a place we go where there's no cell phone coverage, no running water, no toilets, nothing.
It's
awesome.
Just nature.
Absolutely.
That sounds perfect.
Yeah. That's beautiful.
Hi, Bronnie. Thanks for coming on.
My pleasure. Lovely to see you. It's wonderful.
So you have quite a resume at this point, with quite a background in rehabilitation and dealing with people in pain. How did you get started with that? What drives someone to want to deal with people who are in pain all day?
By accident, kind of. I was working in a rehabilitation centre, and most of the people that I saw, and this was mainly vocational rehab, and most of the people I saw had pain as their major problem, and I was fairly novice, really. I have my own pain, so I live with fibromyalgia, but of course we didn't know about it then. We didn't have a name for it, but that wasn't how I got into it. But I did have this background in understanding pain from a personal level, and the rheumatologist that diagnosed me with chronic pain said to me these fateful words that everybody with persistent pain will hate to hear: "I'm sorry, there's nothing I can do for you. You know, your heart sinks." But what he did then was fantastic. And he gave me the book, The Challenge of Pain, that was written by Melzack and Wall. And it described the gate control theory. So that was back in the early 1980s. And it was pretty unheard of. What I didn't know was that Mike Butler was a friend of Patrick Wall. And so one of the founding members of the International Association for the Study of Pain. And so this was his personal friend, and here was his book saying, "Here, read this." So I went away reading that, and I mean, everybody who gets a chronic pain diagnosis feels like, what am I doing? I was 22, 23, thinking, this is my life. I'm going to be like this. So I read that, and I did my own rehab because there wasn't anything much there. And then as I went on in my occupational therapy career, I was looking at this vocational rehab area and discovered that so many of the people that I was seeing that were having trouble with their with returning to work were people who had pain as their problem. So I brought that sort of little bit of knowledge of pain with me to decide to try and help them. And so that's how I entered the field, and then it kind of took off. The bug bit, and I haven't left pain ever since.
That's interesting, because being able to experience something, everyone's going to experience pain differently, but do you find that has really helped you having such, I don't want to call it a label, but being told that you were living with chronic pain earlier on, do you find that's helped you really connect with some of the people that you've worked with who are going through similar things?
I'm actually a bit ambivalent about it in some respects, because I don't believe that you need to have a condition to be able to work fruitfully with somebody who's got that condition. You could sort of argue, back in the day when people had alcohol treatment and there was this movement to say you have to have been an alcoholic to be able to treat people who are recovering. And that's been later shown to be rubbish. And the same thing really, I think, applies to pain. But what it has meant is that because of that early understanding that just because I'm sore doesn't mean I'm doing harm, and the fact that I've been able to learn to live with that and experience what it's like to move from I am scared to move to, yeah, I hurt, but it's okay to move. I think that's meant that in many respects I speak across the tide. I've swum against the tide, because everywhere we go, there are people saying, well, you've got to get rid of the pain. We've got to focus on reducing that pain. And once that pain is gone, then you can have your life again. And I know, first of all, that's not possible for so many of the people that I work with. It's a good 10 to 20% of people, perhaps even more, will have to learn to live with persistent pain. And secondly, you can live at the same time as you are becoming well. So you can still be doing your pain management, still be having your treatment, and have a life. And that's the kind of approach that I'm really fond of emphasizing. To wait until it's all gone, you could be a long time waiting.
Yeah, absolutely. I think something that is pretty common actually from some of the patients that have come into my clinic, at least, some of their narratives or preconceived thoughts are, I'm coming to see you so you can take me out of pain, and then I can start doing my exercises and getting back to the activities that I love. And it's always important to have that conversation. Let's start getting you moving and doing the things you love now, and that will help with that process. But how do you approach some of those conversations with individuals that are coming in with that primary goal of just or that fixation on their pain?
I think I use a lot of metaphors, and because I work from within an acceptance and commitment therapy framework, that's the theoretical model that it's a process-based therapy that I use. I think that it's, and I probably have always done this, whether it was a CBT approach or not, I've said, so tell me what's happening for you. What are you missing? And if pain was less of a problem for you, what would you be doing? Can we start to do that and look at your pain at the same time? Can we start to enlarge what's happening for you so you get more of you back in the process of learning how to live with this and perhaps reduce your pain? We don't know what's going to happen with pain reduction. On the one hand, there's lots of research and there's been billions of dollars spent on all sorts of approaches to treat pain. On the other hand, persistent pain is a thing. 1 in 5 New Zealanders, and I think it's about the same in Canada, about 1 in 5 people will have pain that's gone on for 3 months or longer. And our effect sizes for everything that we offer, from exercise to manual therapy to pharmacology to surgery to psychological approaches, have tiny, tiny effect sizes. So we have to be a bit modest and recognise that that is probably the situation, and that with the people that we see, I know that some of the people I see have this feeling that there is some goodie tucked away for good patients, and we're keeping it from them because they're not good enough or because they didn't do what we said. And I want to disabuse people of that, because that's false hope. And I think the most tragic thing that I see is when somebody is going through this roller coaster of hope oh, they've got the thing that's going to do it, and then despair. Oh, it didn't work. Oh, this new thing, I'll try that. Oh, it didn't work. And that is the most tragic thing. Living with pain is not such a bad thing. You know, we can have really good, fulfilling, wonderful lives, but we can't do that if we think that that's second best. And we can't do that if all our efforts are placed on trying to control something that often cannot be controlled. We just need to be a little bit frank with people. And from all the qualitative research that I've read, and I've read a lot in my PhD, what people with pain are saying is honesty, be straight up with me, give me like what it is. It's a bit like in the olden days, we wouldn't tell people they had cancer in case they lost hope. And I think now there's this hero complex that some clinicians have, that I'm going to be the one that's going to find the thing for you. And our patients who come to us for help get caught up in that narrative. That's unfair. That's about us and our egos, not about the person.
Mm-hmm. I remember one of my professors when I was in school, he said, if you think that a patient has fibromyalgia, you may not want to tell them they have fibromyalgia, because then they can go and Google it and read all that information about how it's never going to get better and it's painful for the rest of your life. But by shifting the goalpost away from pain management and looking more at function and what they can do is generally much more conducive to their recovery, I suppose.
The thing is that people are looking up their symptoms anyway.
Mm-hmm.
You know, somebody will Google, I've got pain everywhere, and they will come up with this label, fibromyalgia, only it might be called something else, myositis or myalgia or something, and they may get an even more, I don't know, dangerous, if you like, belief about what's going on. So I think people like, well, from my research and reading the qualitative research, people need a label. So they've got this convenient word they can use to tell to other people, this is real. I'm not imagining this. I'm not faking it, and take me seriously. So I think that it's a little risky not to use the term. What's more important is to say, so this is how it is at the moment. Let's help you join the dots of your experience. And let's focus less on the title and a lot more on what is it like to be you? What are the things that change your pain? What are the things that don't change your pain? What are the things that bring you alive? The things that bring you down? And how can we look at yourself and the people around you to create a life that's worth living? Not just a life that's focused on, can I get rid of the pain for you?
Mm-hmm. You brought up a really good point there when people are trying to maybe not get validated, but they want to show proof that they do in fact have something. And I mean, a short story, I almost went through this myself. I had a pretty significant hamstring injury and I was given crutches because I couldn't weight bear on it. And most people were just kind of looking at me like, really? Like this, you sure that something's really wrong? And then 2.5 weeks later, that's when my bruise showed up, which was from like my glutes all the way down to my ankle. And then people kind of believed it, right? And in school, we were taught Waddell's tests. And if you actually read his materials, like he has some phenomenal work. But we were taught these tests as being able to find like malingerers or people who are trying to fake it. I don't agree with that, but like, how have we got to this point where people just aren't believing other people's experiences? You know,
Waddell was a wonderful, wonderful man. So I don't know if you know, he's an orthopedic surgeon who got walked by Chris Main, who is a clinical psychologist, big Scottish, hairy-faced man, and they started to work together to try and see, was there something else that we could do, given that surgery isn't working very well. And what Waddell's signs were developed for was to actually identify people who had a need for more psychological assessment. it was taken by the insurance companies who were, especially in the States, who were desperate to find a way to get rid of these people for whom we couldn't see what's wrong on imaging. All we had was their statement that they hurt. And there's a moral sense of judgment about people who don't fit the box. And the prevailing model of pain through the 80s and earlier was that if you didn't have something we could visualize, something, and it still exists, particularly in the States, if we can't see it on X-ray, it does not exist. And Waddell was saying, but hold on, there are other explanations. And the Back Pain Revolution was the textbook that I used to use for teaching. It's a wonderful book on how people present with less disability when health professionals get the hell out of there, particularly medical profession. That people, yes, they have pain, but they're not disabled by it. So I think the judgment comes from people believe, our experience as people is that when you have a pain, it will go away as your body heals. That's what we all grow up with. And so when somebody doesn't follow that rule, we look at them sideways and we think, what's going on with you? And because there is a compensation was built on workman's compensation, let's compensate you for something that should not have happened, then there is this belief that you're in it just for the money. In New Zealand, our accident compensation is a national compensation insurer. Everybody has 24/7 no-fault insurance. So there's no litigation. You get 80% of your weekly income as your compensation. So it's not overly generous. You can ask for a lump sum and have that assessed when you're medically stable, but it's like about $150,000. You are not going to buy your house with that. You get your treatment covered, and you get your rehabilitation covered, but that's it. So it's not a lot, but there is still an attitude inside the way that the legislation's written, and this applies across all of our insurers, that says unless we can find what's wrong with you, then you can't have the problem. Obviously, you're faking. So I think it's endemic in like a social contract that we have in our community that will give you this provided you do your bit. And what seems to happen is that there's the perception that people who don't recover, basically they're not doing their bit. You know, we've given you all this recovery money and rehab, and you should be getting better. How come? Well, clearly it's because you don't want to get better, because we like simple. We could apply the same argument to people with brain injury, and we do. People with post-concussion, as I know, I had 2 years of recovery with my concussion. It was awful. I lost who I was in that period. And towards the end, there were people at work saying I was just basically not very motivated to come back to work, that I was going home and playing computer games. Well, yeah, I was actually, because that was my rehab. And I was sleeping for 2 hours every day. You tried working like that, but it violates the social assumption of this is the predictable recovery trajectory. And anytime anybody does that, doesn't look normal, we just look sideways at people. So I think that's where it comes from, and the assumptions that if you have a problem, we ought to be able to identify, you know, the source. We should see it. There should be evidence. Somebody's word is just not quite enough.
Mm-hmm. It's funny.
Off my soapbox, sorry.
No, it's funny because like you can see it as these different technologies arose too. Like when the X-ray was more popular, we had a lot of osteoarthritis as a diagnosis. When the MRI became more popular, we started seeing, well, disc bulges and disc herniations for low back pain, for example, were the cause of back pain, right? So you can really see where it's coming from that, right?
Next it'll be brain imaging, but you know, even that is only showing changes in blood flow. That's all. That's not equivalent to showing that somebody's got pain. It's just saying, hey, here's what we think might be a correlate, but we don't know. You know, that is our problem, because pain is a subjective experience that somebody tells us or communicates to us in some way. And that means it's an interpersonal thing where we've got two people who need to agree that, yeah, you've got this happening. We don't need two people to agree. I can say I've got pain and nobody can believe me, but I know. And in order to get help, I need to convince somebody else that this is my experience and it's true. But we have lots of disorders like this. You know, it's easy enough to point to fatigue, to concussion, to depression, to anxiety, all the mental health disorders. We have no evidence, can't take a blood test. But the problem with pain is that we've got this normal experience that we all have, and the subgroup of people that don't fit, which is pretty sad.
Where you were going with that, so let's say we have just a layperson listening to this, how would you describe to them pain as a perception, or what it would be your definition of pain? Because oftentimes it's more just from a nociceptive standpoint. That's how a lot of people understand it. So how would you explain that to a new patient who wants to learn a little bit more about what's going on?
And as a follow-up to that, I also want to hear what are some of your favorite pain metaphors? Because you said you like to use metaphors. I want to hear your best ones, because metaphors are such a great teaching tool.
Yeah. So first of all, I know that the people I see have probably been looked at askance. People think, oh, are you for real? And with my experience of my concussion, I also experienced the sense of, what if I'm making this up? What if I'm actually just being, you know, questioning my own experience and the validity of my own experience? I don't do that with pain, because I've been living with it for, you know, a long time, 30 years or so. 30, yeah, a long time. And so I don't question that now. So the first stance I take is that, you know, you have an experience. Let's help you connect the dots of your own experience. You tell me what goes through your mind when you saw. How do you show people that you saw? What's your theory on what's going on? How do people know when you saw? What changes your pain? What makes it worse? What makes it better? And I map all of that out in a big mind map. I draw on the theories that they've had. So, you know, I say something like, people have given you lots of explanations. What's your theory? How do you put all the stuff that you've been told together to make sense of it? And then we map that down on this giant mind map. And then we start talking about real examples. Like, I wonder if you've noticed, why do you think it is that a paper cut, a little tiny injury, but oh, it hurts so much? Why is that? And because we're rugby playing nation, I'm not a rugby player, and I don't like rugby. But because we're a rugby playing nation, everybody knows about these brutal guys going out on the field, and they're hurtling into each other, damaging themselves and playing on despite injuries. How come? What's going on there? And I'll use examples like, you know, when somebody's had an amputation and they've got pain in the part of the body that they don't have anymore. How do you make sense of that? So I use these common, well-known experiences. It's like the car crash, and the person gets out of the car, they can roll the car over, they can rescue all the people out, and they've got half a leg missing and they don't even notice. How does that happen? Or people who've done netball is apparently not a contact sport, but any woman who's played netball will know the next day they'll discover bruises on themselves that they just think, how did I get that after playing a game of netball? And so I use the everyday experiences of the person to poke holes in their assumption that there is a direct relationship between what's going on in the tissues and their own experience. I ask them, are there times when pain's really in between your eyeballs and time when it's kind of back here somewhere and it's not bothering you as much? What do you think's going on there? So I don't explain pain. I don't believe in doing that. I help people connect the dots of their experience because they know that. And then we can say, so I wonder if there's a disconnect between what's going on in your body and the experience that you're having. And I wonder if that's a bit like, so here come the metaphors. The fire alarm, the smoke alarm. Now we've all had a smoke alarm go from burning toast. Why do we do that? Why do we have an alarm that goes off when there's no fire? Because we want it set early so we don't have a fire. So normal pain's like that. It tells us in advance. And the definition, and I'm going to use the old IASP definition of pain, is that it's an unpleasant sensory and emotional experience that's associated with actual tissue damage, potential tissue damage, or it's described in those terms. The potential tissue damage is the one that we forget about. But try sitting and not moving. Just try that for a while. Try not blinking. Just try it and notice. And you know, when you pull your hand down like this, just feel that. What's that about? Have you damaged anything? No, because that experience that we know of is primarily there to act as a warning. And then I might talk a little bit about, I use Wolf's classifications for mechanistic classification. So we have nociceptive and inflammatory pain. Now, nociceptive pain is just activation of the nociceptors. So we've got mechanoreceptors, thermoreceptors, and chemoreceptors. And we can have everyday examples of chopping up an onion, chemoreceptors. We've got thermoreceptors. Try holding onto an ice cube. Just try it. Or a really hot cup of coffee. Try mechanoreceptors when you're sitting there. And usually I'm telling my fifth year medical students at this point, and they've been sitting there for half an hour. So that's normal. And we don't tend to see that stuff. We do when it's perhaps got a bit more long term. So somebody's got, I don't know, a bunion. That's a nice biomechanical change. We've got changes in the way that the joint is functioning. That's painful. That's nociceptive. But most of the time we don't see it. Inflammatory pain's a bit different. Now we've got some tissue damage. And the best example of inflammatory pain that I can use is sunburn. So there's characteristic features of inflammatory pain. We have hyperalgesia and we have allodynia. So allodynia, and we have spontaneous pain. So when you've got your sunburn and you're sitting there, which is probably going to happen a month from now when we first go out and enjoy, you know, spring, summer, sunshine, you're just sitting there and you burn and it's hot and it's red. That's inflammation for you. And then you jump in the shower, and you know, that first moment when you jump in the shower and it feels to your hand quite nice, and then you jump in the shower and it hits your sunburn, right? Ow! that is allodynia. And when you rub your skin, that is allodynia when you're drying yourself off. And then when your mate says, "Hi, how are you?" and whacks you on your sunburnt shoulder, that is hyperalgesia. So we have inflammatory pain, and some of that's clinical, and we'll see it. Sprain your ankle. But often we don't. You know, if you've got a cat scratch, you don't generally have to do very much about it. But we also know it's there for a reason. It's there to say, don't be such a dumb thing. Don't do that again. And by the way, take a little bit of care while this area starts to settle down. Very cool. And then we've got our two weird ones. And I'll talk to people about that. And the reason I talk about these different mechanisms is for the patients that I see, they still think there's a magic pill stashed away for good people. And I want to disabuse people of that. We have really bad analgesia. It doesn't work for most people. And even when it does work, it's a very small reduction in pain. Cannabis is a really good example. 10 millimeter reduction in pain on a 0 to 100 millimeter scale. That's teeny, a little change. So we have neuropathic pain, and for neuropathic pain, we know where the problem is. We can identify it through nerve conduction. We know there's an identifiable lesion in the somatosensory system. So that's easily identified. It's just that we don't have good treatments for it. And then we have nociplastic pain, which is the weird stuff, which is the stuff that I have. It shifts the set point at which I respond. So pressure pain threshold for me is much sort of sooner. You don't need to apply so much pressure. So that's the way that I talk about pain, to say, really, we don't use opioids for neuropathic pain and for nociplastic pain because, frankly, in nociplastic pain, I've got really bad opioid receptors. They are already occupied with stuff that's going on in my body. So it doesn't respond. It doesn't help me. And all you do is increase the dose until I'm sedated and then I'm no use to anybody. I might be calmer than I am right now, but But so I just go through that. So then I can use metaphors from the person's life. So I'm a fisher person. I like angling. And so if I've got somebody who's also a fisherman, I will talk about the way, you grab a fish hook and you know how it catches onto absolutely everything. You guys fisher folk?
Sometimes.
No?
I like drinking beer in a boat.
Yeah, me too. But standing by the side of the river when it's raining is a bit of a definition of a madness. But so you talk about the fish hooks, and everybody who's ever fished knows that if you catch a fish hook on your clothing, it's stuck and it takes you ages to get it out. Well, pain's a bit like that. When you have pain, it gets caught on stuff that's important to you. It stops you from doing what you went there to do in the first place. So what do you do to get rid, to pull a fish hook out? How do we get unhooked from a fish hook?
Keep pushing it back through, right?
Right, you have to go in so that you can unhook the barb and pull it out. Mm-hmm. So in a lot of ways for pain, we need to learn to soften and go into the experience so we can find wiggle room to get out of it. And that might mean saying, okay, instead of fighting with my pain, what if I just allowed it to be present and just noticed it? And even though, say I've got a flare up at the moment, even though I've got the flare up, can I bring my pain with me and sit and chat to you guys? Well, yeah, I can actually. It's the relationship to my pain that matters. And for me, I know that it's just noise. It's like noise in the system. I don't think it's anything harmful. It's not stopping me from doing anything. It's a bit annoying and it's always present, but it's just there. And I guess that's the way that I talk about pain with patients. Right? We can use any example, any metaphor from that person's life. Motorbikes. Because I always end up with motorcyclists. I'm an ex-rider, and I have a little Honda Cub in bits, a C90. It's a little scooter. It's in bits in my garage, and the engine is beautifully restored, but the frame needs a bit of work.
That's your current project right now?
One of many.
Yeah.
What you can't see behind me is this is my silversmith studio. So I've got photography and silver stuff and books and all sorts of creative processes happening in here.
Lots of mercury fumes really going to stimulate the creative juices.
Not quite like mercury, but lots of silver. So with somebody who's a motorcyclist, and we're talking about what is it like when you're riding and you've got all of your attention on the road and you feel at one with the machine and you don't notice anything else. That's mindfulness. And that's what we're trying to develop for your pain, so that you're focusing on where you're going and you're at one with what's happening in your body without fighting it. If you fight against your motorbike while you're going around the corner, you're going to come off. So let's use that same metaphor with how you manage your pain. You have to have your tyres pumped up. So if you've got your tyres inflated to the right pressure, it makes cornering a lot better, as well as the tread. So what pumps your air up? What makes you feel like you've got that resilience and that robustness? What gives you grip and grit? How can you, so we just use lots of different ways to help people understand that it's their actions that make the difference in their relationship to what's happening in their body that makes the difference to whether you are in a battle or you're in a dance.
So for anybody, like, just press pause and then go back and then listen to all those metaphors and write them down, because those are fantastic.
What I do is actually give, in an audience, I'll give people just random objects that I can find. Lipstick, a camera, a phone, a pen, a car, well, maybe not car keys. And then I just ask the audience to come up with how's this object like pain, or like living with pain, or dealing with pain. You'll be surprised. And the more versatile you are with using things that this person knows about, the more you're able to come in on their wavelength. And the metaphors work by providing a bridge between something that's common and familiar to something that's uncommon and different. And so with pain, we know that the harder you struggle against it, the harder it is to deal with. So I'm looking for opportunities to help somebody see that by going into that experience, it might feel different. So the finger trap is a really good example. We can use that. Or we can use the hooks. So we can use something the person knows about to help them see that the harder I pull against pain, the more trapped I feel. Harder I try to control the pain, the more difficult it is to actually do anything. I need to go into it and be a little bit more flexible. Mm-hmm. So yeah, lots of ways of looking at it. I've got a big book of, where is it? Big book of acceptance and commitment therapy metaphors that you can use. Wonderful.
I've got a very useful book here that I use as well for clinical practice as well. That is the book of 101 Great One-Liners.
Dad jokes. All of them. Wonderful.
As I say, laughter is the second best medicine. The best medicine is medicine.
Yeah. That works. I like that placebo works quite nicely.
Yeah. One area that I did want to touch on with you is that you're all talking about embracing pain and being able to live life through it. And this is one area where I believe, and the research is pushing away from pain management more towards function, is using exercise as a therapeutic intervention. In the sense that it teaches people what they can do for themselves, teaches them to become active, and especially when the effect sizes of pretty well everything for actually managing pain isn't very good, and it's all similarly not very good, we should be changing our perspective and changing our goal to a different outcome, in one case being function and other overall health. So with exercise, you get all the other great benefits. You get to build muscle, increase your cardiac output, increase balance, and all the other things that are great predictors for overall quality of life. What is your perspective on exercise as an intervention and the best way to apply said intervention?
This is a leading question. So I don't like the gym. I am not a gym bunny, and exercise is frankly boring. So if you like exercise, go for it. What I like is meaningful movement, as long as, so the effect sizes for exercise are also pretty pitiful for pain reduction, and they're not great for disability reduction either. So we do it because it's got good evidence, it's strong evidence, but the effect sizes are little. So from that, I take that first of all, there are no specific exercises that work better than any other exercise, and that's across the board. I'm not talking about acute musculoskeletal problems, particularly not tendons and things, but when we're looking at this sort of subacute and then ongoing pain, it doesn't really matter. What matters is that people do something. And people do something if it's meaningful and if they can have choices and options. So for me, I love to go fishing. That means I've got to go carry my fishing rod. I've got to walk over really uneven ground. I've jumped in a kayak. I've got to hift my rod out. I've got to do lots of movement stuff. That's cool. I like to walk my dog. That's cool. I've got to do it every day or else she drives me absolutely bananas. So that's a movement option. I can get up, and I do, every 25 to 30 minutes, not while I'm on this call, to get up and boogie. Put the music on, do a 5-minute snack break of movement. I can go walk along the beach. I can garden. Vacuuming the house, believe it or not, is an exercise form. What we need to have are lots of options that people will do, that they enjoy, not that necessarily that the exercises are intrinsically enjoyable, but that they lead towards something that's important. What is useless is being told as a non-exercise person, you will go to the gym, you will do your three sets of 10, it's going to be good for you, and by the way, I have no idea how this connects with your life, what you want to be able to do, and where you want to go with it. That is a waste of time. And we have a program, our accident compensation pays for programs for people, pain management programs, and often the exercise component is a gym program. The programs last for 3 months, and then the people drop them like a hot potato because they don't care. They're not engaged in it. It doesn't matter. Whereas they could be working on standing tolerance while watching their kids play football. They could be climbing up a hill to look and take some photographs, something I do, and they've got to carry stuff. They can be, jumping on their bicycle and going for it. But there's this sense that if it's to be proper exercise, it's got to be prescribed in a certain way, and it's got to be 3 sets of 10, and it's got to be boring. Frankly, that doesn't work. Dance, I would challenge anybody to come do an hour and a half belly dance class with me and not be sweating by the end of it. That's one of my favourite forms of exercise.
So I'm a big fan of using the word meaningful movement and exploring that, because I remember in some of my earlier clinical days saying, okay, we're going to do some exercise, and you just see someone's eyes just like open up and they're like, I'm not doing that, right?
Yeah. Pops in the headlight look.
yeah, exactly. Now, as I'm very on that side of things, but I have heard a counter argument before. I'm not sure if you've heard the name Adam Meekins.
I love Adam. Adam and I go way back.
That's fantastic. Wonderful. So I've heard him say a little piece on how sometimes there is room for having someone do exercise even if they don't enjoy it, because it will be beneficial. Now that probably falls outside of the realm of chronic or persistent pain, and maybe towards something where you do need more significant loading, say like a tendinopathy or something like that. So would you agree that, to his point, that maybe sometimes there is some room to do a little bit of boring work to get benefit, or should we always really be pushing towards just enjoy something and you'll get more benefit out of that?
It's got to be meaningful. It doesn't need to be enjoyable, but it does need to have meaning. So I'm okay with doing, so I've got shoulder pain. It's probably old age. And so Adam and I had a conversation about what I do for it, because, you know, if you've got smart friends, you use them, right? And yes, I did some strengthening stuff. But what I did it for was so that I can go out and do my wisteria pruning, because wisteria is a vine that requires taming. So what you need to do is say, why does this person want to be out? What would this person be doing if their pain wasn't such a problem? How can I help them do something that's meaningful to get them to that point? What I'm seeing in these fairly cookie cutter exercise programs is a generic, I'm going to get you cardiovascularly fit. That is not worth it. But yeah, nothing wrong with getting strong. And, you know, Adam's really good at describing really innovative ways of getting people to do stuff that is hard work. What I don't want to see is do these exercises because I tell you to, and I can't see how they connect with this person's life. There has to be a review point. There has to be a way to measure progress. There has to be a way to make it meaningful, or else people won't do it. People don't like following rules, as you know.
Yeah, I think we sometimes break some of the rules ourselves with some of our viewpoints, traditional rules anyways.
Careful.
But on that note, I heard you talking about how, like, it's important to improve someone's, you know, daily activities and function, and that's probably more important than lingering on pain. And you usually leave the word pain and the focus on that in the first appointment, and focus on some of the other things a little bit later. But you also said sometimes, like, those scales that we use, they're not necessarily an objective measure as some people put them out to be, but it almost sounds like you use it as a surrogate to measure their daily function. So if, you know, one day they said, well, I'm at a 6 out of 10, then maybe that might be more in relation to their lack of ability to do the things that they love. Is that something that you do, or do you just kind of throw that out the window and really focus on more important measures?
I don't. So pain intensity scales are rubbish. Well, I'll reframe that. In certain contexts, they are useful. If you go into the emergency department and you say, I've got a 3 out of 10 pain, they will laugh you out of the ED. If, on the other hand, you say you've got an 8 or a 9, they'll probably give you something. That's probably what you want. So there are places where pain scales are a communication aid. When somebody, and I don't measure pain, we do a battery of questionnaires at the beginning, and that's to give me enough information to generate a formulation. And we do them at the end and at follow-ups, because 3 data points give us an idea of what this person's response is like and what's going to be durable over time. Am I doing a good job as a therapist? But when I'm talking to somebody, I'd rather know what they're doing than what their pain is. So if somebody says, oh, I had a really bad flare-up and so I didn't do very much this last week, if we were to use sort of a behavioural approach, what we want to do is reinforce well behaviour, reinforce what we want to see more of, and not reinforce things that we don't want to see. What we don't want to see is somebody focusing on their pain, because if you focus on your pain, it becomes much more salient and more prominent in your mind. So if I hear somebody say, oh, look, a really bad flare-up, and I didn't really do very much this week, but I've come in to see you, I'm going to say, hey, really sad you had a bad week, but isn't it great that you came here, even though you're sore, because now we can do something to help you do what's important. What did you manage to try? What did you experiment with? What can we change? so that we're looking at reinforcing things that we're looking for. And I'm not using a measure. There's a thing called a recovergram that we can use. And this is quite nice. You put 4 things that the person really wants to be able to do. And like the patient-specific functional scale. And we just track it on a spreadsheet. And we track how well people are going on those 4 activities over time from a 0 to 5 Likert scale. 5 is I'm doing it the way I want to. 1 is I'm not doing it very well at all. And that's more of a global impression scale. And that gives me some food for saying, hey, you had a bad time 3 weeks ago, but look how much you've been progressing. So it's more of a indicator to the person. But it's not something I want to focus on because, it doesn't help. And
Right.
pain intensity certainly isn't correlated well with what people do.
For sure. And people can often get very stuck on that, right? Actually, speaking of metaphors, Elliot does have a really good one about this, the ruminating and the microwave. I don't know if you want to say that, but
Go on.
Yeah, so it's the idea that have you ever put food in the microwave and it takes forever if you just stand there and stare at it to cook?
Yep.
But if you leave and go do something you enjoy, it'll be done in no time.
Yep. It'll boil over more like.
Maybe that's another metaphor, but the idea that we're better off spending our time doing something we enjoy than ruminating over something that we're not.
Yeah. And that's absolutely true. The trick is, how do you stop brooding on stuff? And that's where I'm going to use mindfulness. And believe it or not, last night we have a howling northwest wind, which is a really hot, dry, pollen-laden wind. And it was going nuts last night. So I didn't sleep very well. And while I was lying there hearing the wind howl, I was just letting my mind have its thoughts and let them just wander and just noticing as they were going, doing my breathing. And that's a practice that I think is really valuable to stop yourself from brooding. So noticing my breath is, I'm still going to have that rumination happening. But every time I notice that, I can be kind to my brain and say, thanks, mind. I know that. Let me focus on my breathing, because that's more interesting. And you can get quite fascinated with breath if you have a mind to enjoy it. And minds like that sort of interesting thing, sensory experiences of it. So that's what I would do.
One other question here. We had a conversation online a little while ago about the uses of passive therapies for treating pain. Now they don't particularly have a great effect size, just like everything else. But considering that the majority of people who treat musculoskeletal pain do employ manual therapy to some degree, at least as a profession, chiropractors, physical therapists, massage therapists, osteopaths, these are all big players in this role, and they're all employing some degree of manual therapy. Where do you think that it plays a role in rehabilitation of pain, as well as kind of using that therapeutic window of opportunity, whether you have a just answer the first question there.
Well, this is where Adam Meekins and I differ, because I do think there can be a place for hands-on therapy. I don't know about the window of opportunity, because I do know that we used to use the argument, there's a window of opportunity with epidural steroid. It reduces pain, people will move. And I've seen that same argument applied to lots of interventional approaches, anesthetic procedures and needling and whatever. And I haven't seen much demonstration of people with pain using those approaches. I think hands-on therapy is a slightly different thing. So if I talk about, for many people, it's the first time they've been touched in a non-sexual way. So it is, and touch is meaningful to people. It's about connection. And I think there is something to the communication that can occur between two people when one is touching the other in a therapeutic way. So there's an opportunity for communication. There's, as Rachel Kitt, my favourite massage therapist, and her offsider Odette Wood, both registered massage therapists here in New Zealand, they talk about the fact that when you see a massage therapist, you think of the hands-on part. What you forget is the assessment, the conversation, and the discharge, at the end of it, the review and the home-based stuff. And as a package, that is what we're really talking about when we're talking about hands-on therapy. It's not just the hands-on part, it's that packaging around it. And it's entirely possible when you've got someone who is vulnerable with you, which is what you have this intimacy when you lay hands on somebody, skin on skin, that is not present with other forms of therapy. And that intimacy allows a conversation to occur that's not, in a relationship to occur, that's not going to happen as readily in other ways. You can use that for potent good. The question is whether it's used that way. So I was 80s and 90s. Passive therapy in New Zealand was really dealt a massive blow by our accident insurer, who said, right, we're going to stop funding years of multiple sessions of hands-on therapy. And we will let you do 6 treatments and then that's it. I don't know why 6, but 6 became the magic number. And people had to say what the benefit was. So I'm of a generation, I suppose, that says that it's possible not to use it, but it also can be helpful. So I think it gives people a sense of their body, of movement possibilities. I think it gives a interpersonal moment. Short-term effect sizes. Small effect sizes and very short-term effects. And that's probably the major risk, that for humans, we are habit-forming creatures. So if we get an immediate result from something, we're going to want more of it. And the risk in what our ACC was trying to stop was this ongoing dependence and reliance on hands-on therapies, which was a big business here. I had people who say, I've got 365 physiotherapy appointments and they gave me acupuncture and hot pack in a minute. That's a lot of therapy with not a lot of improvement. So I want to see some changes. I want to see the person able to do more. I want to see the person feeling more confident in their movements and having that connection with you to a point where they feel they can trust you. That's what hands-on therapy builds.
That was probably a great way to end it. Like that was a great answer. It's very in line with what I've heard Kieran O'Sullivan talk about in terms of building relationships and reassuring with the hands. That's a great way to implement it, right?
Because I don't think we're doing anything else particularly powerful. I think we see short-term changes, but I don't think that translates into longer-term effects. And that's just my observation, reading of the literature for a long time. But then I'm a skeptic for just about everything. Because in my experience, nothing's changed my pain. So I don't expect that for many people, the majority of people I see, their pain might waver about an average. But any little shift is nice, but it's probably going to flare up again, and they want to have some stuff they can do. And that probably matters more than what I can do to them.
Mm-hmm.
Yeah.
High value versus low value healthcare, right?
Yeah. And it's our words that carry more power, I think.
Absolutely. Absolutely. Bronnie, thank you so much for coming on and sharing some incredible insight and metaphors and stories. We really appreciate it. If you have maybe any resources or links for the listeners to, get a little bit more Bronnie Lennox Thompson, what would those be?
My blog is probably the key area. So it's www.healthskills.co.nz. And I've been blogging since 2007, and it was part of my rehab for my brain injury, my concussion. And I just carried on. So there's a lot of stuff on there. I've no idea what's still there.
So it wasn't just computer
but
games.
But it's worth having a look. It wasn't just computer games. It was writing, thanks to the speech language therapist. Otherwise, I'm on Twitter. I'm on Facebook a lot. I've got an Insta thing, but that's really silversmithing and dogs and flowers and travels and beer. No bacon yet. Bacon comes.
That should be next on the list.
Yeah, maple syrup and bacon.
Okay, Bronnie. Yeah, thank you so much again for coming on and sharing with us.
Absolute pleasure.